I'm Christine with the foundation. I'm one of the clinical research managers. And I'm presenting Artesia, which is a study with Dr. Moore as the PI. Jake Cohen, one of our coordinators, is the coordinator for it. And the study is subclinical AFib detected on device. So patients who have at least 6 minutes but less than 24 hours of AFib that they detect on device can be potentially qualify for the study. There are some risk factors that certain risk factors for stroke that they have to meet in order to qualify. But basically they're randomized to apixaban versus aspirin. And then they're on that for 3 years. If at any point during the study they went into clinical AFib or developed AFib longer than 24 hours, then they would be out of the study and be put on apixaban. But since this was discussed with the EP group quite thoroughly, that they just don't know the answer or what the right treatment is for these folks that have this short-term AFib, so decided to proceed with the study. We're doing it. We won't get a lot of referrals because all of our referrals will come from the device clinic and they'll detect it, but you might see these patients, with this study labeled on their chart, and you'll know a little bit about it, and we'll have our contact information with that if you have any questions or any concerns. But every patient we'll discuss with the EP group. We also are working with neuro because some of their patients will be crossover with ours with this study, so they're on board with it and supporting it. Any questions?
Thank you, Christine, for the update. And we do have a distinguished audience here that made it in this morning, so congratulations to each of you. This morning, I am privileged to introduce Amit Sharma, who's one of our fellows. Anybody who has worked with Amit is immediately struck by his work ethic and his intellect and his clinical acumen. So we're really fortunate to have Amit this morning, who's going to share with us his title, which is "What is that and why is it there?" Something we can all relate to that. So thanks, Amit, for putting this together for us.
All right, well, good morning, everybody. Thank you, Dr. Sharkey, for that very kind introduction. Hopefully everybody had a nice weekend of shoveling from the looks of it. So I'm going to get started. This is going to be kind of an interactive type case carousel presentation. We'll go through lots of images of cases, studies that I've either done or patients I've taken care of personally. And if you have any questions at any time, just go ahead and ask. So my objectives for today, we'll go through a differential diagnosis for intracardiac masses, talk a little bit about surgical intervention and indications in infective endocarditis, and then talk about the pathophysiology and management of myocardial aneurysms and pseudoaneurysms. I have no disclosures, so we'll get started. The first case, 41-year-old male that presented to the emergency department about a month ago here with a chief complaint of left ankle swelling and pain. He had been traveling from Utah to Minnesota to visit his father. And on further questioning, he'd mentioned about 4 months of kind of constitutional symptoms of night sweats, weight loss, low-grade fever. He'd had a pretty extensive general workup, including infectious, with blood cultures actually in Utah, without any clue to what was going on. So when he first presented to the hospital, his blood pressure was 149/42. He was tachycardic, heart rate was 133, and febrile with a temperature of 37.8. Really, his labs were pertinent for a hemoglobin of 8.8 and a mild elevation in his creatinine at 1.29, and we didn't have any baseline labs at this time. So when he first presented, there was some concern that perhaps he'd had cellulitis of his left ankle. There was some swelling and erythema, but lots of pain with joint manipulation, so they thought a little bit atypical and decided to tap the ankle. Had a small amount of fluid that was returned. They worked him up for a PE given his travel. His CT showed no PE, but they'd mentioned an enlarged left ventricle. on the study. And so he was admitted for further workup and a transthoracic echocardiogram. And they also did a CT of his abdomen and pelvis, which showed some splenomegaly and then a wedge-shaped lesion that was suspicious for infarction. So we'll go through these studies, these images here. So this is a parasternal long axis. For those of you who don't look at these every day, left ventricle here. This is the mitral valve, left atrium, aortic valve, ascending aorta, and right ventricle here. As you'll notice, kind of the most obvious finding here is this large mass on the aortic valve, and then there's a suspicion of some thickening here of the mitral valve as well. Zooming in here on the top right, you can clearly see there is a mass of some sort on the aortic valve that's prolapsing partially into the left ventricular outflow tract here. And this is a color Doppler study. Really what you see is a little bit of mitral regurgitation down here at the bottom of the screen, but the most important finding here is there is just a lot of aortic insufficiency, which is that color jet back into the left ventricle. And this is a short axis view. As you can see, this is the aortic valve here in short axis, and there is that mass once again shown here, and then on color Doppler, a lot of aortic insufficiency, which is basically the color jet you'll see in diastole. And he was a little bit tachycardic at the time of the study. So apical four-chamber view here. Once again, you see suspicion that there's something here on the mitral valve. The left ventricle is dilated here, and that's an important finding for reasons we'll talk about later. Zooming in here on the mitral valve, once again, thickening appreciated of the mitral valve. And then on color Doppler here, you see really the most important finding here is there's probably about at least moderate mitral insufficiency here by color Doppler. And then to the top left here, we have a pressure half-time, which is markedly reduced at 83 milliseconds, which would suggest severe aortic insufficiency. On the bottom right, this is a Doppler of the descending aorta, and this here represents diastolic flow reversal in the descending aorta, which would suggest severe aortic insufficiency. So we went through the findings. The only additional thing here that we didn't talk about was he also had an ascending aortic aneurysm that was measured at 4.4 centimeters. And cardiology consultation was requested at this point. And his physical exam was notable for a 3 out of 6 diastolic murmur, which fit with his aortic insufficiency. A 2 out of 6 holosystolic apical murmur would fit with his mitral regurgitation. And he also had splinter hemorrhages in multiple nail beds, which is really suggestive of infective endocarditis. So at this point, we proceeded with a TEE to further evaluate both his aortic and mitral valve. So this is a mid-esophageal four-chamber view here, and I think right away you can see there's something very abnormal here on the anterior leaflet of the mitral valve. You don't get a great look at the aortic valve, but once again, you can at least partially visualize that, that mass there on the aortic valve. And this gives you a better look at it in the top right. There is a mass right here in the aortic valve. And this is a zoomed up view of the mitral valve here. That is very, very abnormal. And I think we have a color Doppler shot of that coming up. That measured at 1.27 by 1 centimeter on the mitral valve. This is another look at the mitral valve here as you see this abnormality of the valve on the atrial aspect of the mitral valve. And this is color Doppler through the mitral valve. So there is mitral regurgitation where the leaflets of the mitral valve meet. Also, you can see there is a color jet into this circular orifice, as well as some color flow from within into the left atrium. So our suspicion was that this person had, this was kind of more of a prior or more remote endocarditis with a healed aneurysm of that part of the mitral leaflet. And this, once again, is a kind of a similar image showing both mitral regurgitation through the coaptation point of the valve, as well as into that, what's felt to be that aneurysmal component of that anterior mitral leaflet. And this is a short axis on the bottom right here of the aortic valve. It shows a bicuspid aortic valve with fusion of the left and right coronary cusps here, as well as the mass that you can see, not quite as well visualized here as in the parasternal long axis. Once again, looking at the aorta there, in the top left here, there is diastolic flow reversal in the aorta. This is a pulmonary vein shot. All four of the pulmonary veins had very nice waveforms here, but really what you see is systolic blunting, not a lot of systolic reversal, which would suggest more moderate versus severe mitral insufficiency. So we went through, this was the formal read on the TEE. So really at this point, all of the findings suggested endocarditis. He had had blood cultures ordered on admission, which were negative. It was worth mentioning he didn't have any empiric antibiotics given at any point during his course prior to presenting here. And so he actually remarkably had remained hemodynamically stable. And the suggestion or the thought was that this had been going on for some time. His left ventricle was dilated, which would suggest the chronicity of this. And that's probably the reason he was tolerating it well. If this was acute aortic insufficiency, this would be somebody that was incredibly sick up in the ICU with pulmonary edema. So cardiac surgery was involved, and they obviously recommended surgery on both the aortic and the mitral valve, but they wanted to see if his blood cultures were turned positive to get some type of clue as to what the organism was. And then the final issue, which becomes more of a social issue, is that this gentleman was traveling from Utah and didn't really have health insurance coverage here, and was very worried, understandably, about the financial repercussions of what was to come. Eventually, his blood cultures from admission did turn positive for Cardiobacterium hominis, which is one of the Haysick organisms, and these, if you remember, are traditionally very challenging to culture. And also Propionobacterium acnes, and really this was felt to be an oral organism. Propionobacterium is more of a skin organism. Eventually, the left ankle arthrocentesis from admission also returned positive for Cardiobacterium. His antibiotics were narrowed, and eventually, after looking kind of at all of his options, he had decided to go back to Utah to have surgical intervention, and has since been seen in multiple clinics and has really had no change in his clinical circumstance and is doing well. So really to start with intracardiac masses, so there's lots of things that any of these masses we see on a daily basis can be. You can characterize them by where they are in the heart, what they look like, and signs and symptoms associated with it. Oftentimes these are found incidentally when we're looking for something else, but depending on where they are and what they are, you can have peripheral embolization, obstruction if the mass is large enough. If the vegetation, the valve can be destroyed and there can be significant regurgitation. You can also have involvement of the myocardium as well as the pericardium, and then really, constitutional and systemic symptoms as well. Echo is usually the first modality as to how we find these, but we can use CT and MRI to further characterize these if needed. And so really looking at a differential, the things that any intracardiac mass that you should always consider, so anatomical variants, which we'll go through some of those, implanted devices, and probably the three most common that we think of from more of a pathologic standpoint are thrombus, vegetation, and tumors, whether those be primary, which are much more rare than metastatic involvement of the heart, and artifacts as well. So anatomic variants, things that we see. So in the left atrium, you can think of pectinate muscles and the warfarin ridge, which are clearly seen doing transesophageal echocardiograms. The right atrium has the crista terminalis, the eustachian valve, Chiari network, and any device leads from a pacemaker or defibrillator. In the ventricles, you'll see non-compaction as well as moderator and muscular bands. Valves can have calcification, excrescence, which we'll talk about, pericardial cysts and fat, and then lipomatous hypertrophy of the septum are common intracardiac quote-unquote masses that are anatomic variants. And this is just a chart. We're not going to go through this in detail, but really looking at where the mass is, what the relation is to that chamber, gives you an idea really of at least a differential diagnosis and a framework for evaluating any intracardiac mass. So these are just some pictures I found of normal variants. So here at the top left here, you see an image of the eustachian valve and a crista terminalis. Top right, this is a prominent Chiari network. You see the Coumadin ridge here with the left atrial appendage. And then this is prominent hypertrophy here, really, of the intraatrial septum. So thrombus, this is one of the most common intracardiac masses, and oftentimes the clinical history will suggest what this is. So the left ventricle, usually an apical thrombus, is associated with prior anterior myocardial infarction or cardiomyopathy with severely reduced ejection fraction. The left atrial appendage is commonly where we look for clots in atrial fibrillation, and rarely you'll find something in the right atrium, not so rarely whether that's on a catheter or a device, as well as a PE in transit. So thrombi generally are discrete and usually located along the wall of an intracardiac structure, as above, most commonly in the left ventricle or the left atrium. And clinical clues, like I mentioned, will kind of lead you to these. So atrial fibrillation, mitral stenosis, an LAD territory, infarction, and cardiomyopathy. So this was a TEE I did on somebody that we were considering cardioverting. In case you were wondering, we decided not to cardiovert them after this study. But really, this is the left atrial appendage, and you see a big mobile clot sitting here on the transesophageal echocardiogram, and this is at 180 degrees. You can see really most of the appendage in this view is filled with clot. And this is somebody that had had atrial fibrillation for kind of an undisclosed period of time. This was a transthoracic echocardiogram that we did here on a patient. As you can clearly see, this is very, very abnormal. And really what you see here is a central kind of hypodense area, which would suggest that this has been here for some time and is in multiple phases of its development, and really located in a very hypokinetic septum and apical area in this patient that had a prior LAD infarct. And then the bottom is a contrast image, just in case there was any skepticism as to what the diagnosis was here. As you can see, this is a large left ventricular apical thrombus. And just so you know, this guy's echo from 2.5 months before, the wall motion abnormality is still there, but the apex here is quite free of clot. And here on the contrast images, there's no thrombus. So just as a caveat, the traditional thinking is that these happen with the highest incidence immediately after an MI, but I can tell you in my brief history in cardiology here that I've seen these all across time with patients. So something to always keep in mind. So moving on to tumor. So tumor can be located, once again, kind of in a lot of different places. The atria, valves, myocardium, and pericardium. As I mentioned previously, metastatic is far more common than primary cardiac tumors. And of primary cardiac tumors, they're generally benign. Malignant tumors are quite rare. The most common benign tumors that we'll see are myxomas and papillary fibroelastoma, so we'll talk about those. And the most common malignant tumors, primary malignant tumors, are sarcomas. So myxomas, most of these are sporadic. There's a small percentage that have a genetic linkage. Carney complex is the term that's thrown around for one of those genetic disorders where people get multiple myxomas. They can arise anywhere, but are usually connected to the intraatrial septum, and usually in the left atrium, although, like I said, they can be seen on the right and in other places as well. And these are usually found incidentally, but people can sometimes have constitutional symptoms, embolization, or obstruction if they're simply large enough. And as I mentioned, they're oftentimes diagnosed incidentally. So this is an example. Apical floor chamber, once again, not very subtle here, but connected to the intraatrial septum here, big mass prolapsing across the mitral valve. That's atrial myxoma. And then the second most common primary benign cardiac tumor that we'll see, and the most common valvular tumor, is a papillary fibroelastoma. These usually come to light if they have symptoms from embolization. And they can be confused with a Lamble's excrescence, which is usually kind of a quote-unquote degenerative condition located at valve closure sites. You'll see these commonly in older patients, and there's oftentimes multiple of these. So an example from a transesophageal echocardiogram here, you see the aortic valve. This is a papillary fibroelastoma sitting on the aortic side of the aortic valve. And then this is just kind of a run-through of other common benign tumors that we'll see. As I mentioned, primary cardiac tumors that are malignant are generally sarcomas. Metastatic tumors tend to be far more common: lung, breast, lymphomas, and others. And finally, to come to vegetation, so these are oftentimes valvular, and they can also be located on intracardiac devices, leads, sites of prior intervention. The hallmark of these is they're very irregular and variably shaped, but they have independent motion from the cardiac structure that they're attached to. And the location, I have a slide coming up about this, can sometimes be helpful distinguishing what type of vegetation it is. Most vegetations are infectious, but we also have non-infectious varieties of vegetations. And true vegetations generally cause valvular damage, most commonly regurgitation. And constitutional symptoms secondary to this can also be seen. It's just a slide demonstrating locations of various types of endocarditis, but really the valvular type, they're oftentimes ugly looking, associated with valvular damage. Other places you'll see it as this is an example of rheumatic heart disease, and then this is non-bacterial thrombotic endocarditis. The last example is Liebman-Sachs, which is kind of a variety of this. So moving on to the second case, 39-year-old male that had a prior out-of-hospital VT-VF arrest secondary to genetically proven long QT syndrome, secondary prevention ICD in place, and then paroxysmal atrial fibrillation, maintained on metoprolol and flecainide. And he was seen on cardiology clinic about 1.5 years ago. He'd had 10 weeks of constitutional symptoms, fevers up to 102 degrees, chills, and night sweats. He'd been seen in multiple clinics with kind of a negative workup, including blood cultures. Antibiotics had been given, and really he had not been improving. Given his intracardiac defibrillator, the decision was to proceed with the TEE to further look at his device and make sure there was nothing abnormal. Lo and behold, there's something quite abnormal. As you see here, this is a short axis view. Tricuspid valve is right here. You can see this big mass prolapsing into the right atrium associated with the device lead. This is a view of it on an apical 4 chamber. You can see the device lead, and this is just a very large mass prolapsing right across the tricuspid valve. I didn't pull, I don't think I have color images, but really there was only trace associated mitral regurgitation with this. And this is once again a contrast image in case there was any doubt as to what the diagnosis was. You see this large mass flipping back and forth in the right ventricle. The mass was measured at 2.4 by 3.4 centimeters on the ICD lead, minimal associated TR, and there was no obvious involvement of the tricuspid valve, so he was admitted. Admission vitals really pertinent here for fever up to 39.5. His labs were pretty unremarkable other than low-grade leukocytosis. So cultures were drawn. He was started on antibiotics, and ID and cardiology were consulted. And a TEE was ordered to further evaluate these findings and make sure there was no left-sided involvement as well. So here you can see this is the right ventricle here, tricuspid valve, right atrium, device lead sitting right there, and there's big mass attached to the device lead. This gives you another nice look at it here, intraatrial septum here, and just this huge vegetation. It was measured at 3.7 by 2.4 centimeters here. There's another example of it, kind of on an attempted bicaval view, as you see in the right atrium here, large globular mass. His blood cultures eventually returned positive for Streptococcus mitis. He was transferred to United Hospital for complex device and lead extraction. Unfortunately, that was complicated by embolization of the thrombus to his main PA, and he had a PEA arrest requiring an urgent thoracotomy and retrieval of the clot. He was in the ICU for some time, but eventually made a pretty full recovery, was discharged with a WCD, a life vest or a wearable cardioverter defibrillator to allow time for the infection to clear, and then underwent reimplantation of his ICD on the 1st of January. And since then, he's been doing well without any recurrent signs or symptoms of endocarditis. So moving on to infective endocarditis. As mentioned, when it's infective, it's secondary to an infection, obviously, most commonly involving the heart valves or any intracardiac devices. And there's generally a predilection for anatomically abnormal valves, like our first patient had a bicuspid aortic valve, any types of prior prosthetic valves or other prosthetic materials, or damaged heart valves from any etiology. And really what you need is bacteremia. Most commonly this is from an oral source, but the GI and GU tracts can also be involved. And symptoms can be pretty variable, but really constitutional symptoms such as fevers, chills, night sweats, embolic phenomenon can be common, which we'll talk about, and then the sequelae of the valve damage itself, which is usually heart failure from valvular regurgitation. A little difference between left and right-sided endocarditis. Left-sided is more common, and it's generally thought to be of higher mortality, and more surgical intervention is generally required for left-sided endocarditis than right-sided. In the case of right-sided endocarditis, predisposing factors, really IV drug use is something we're seeing a lot of now. Any catheters, lines, devices, and generally, as I mentioned, they're usually better tolerated without surgery, and most often the tricuspid valve is involved. Problems in terms of guidelines and how to manage these people is there's just really not many randomized controlled trials. Most of our data comes from observational studies or retrospective data, and we have far more data for left-sided than right-sided endocarditis. Most of the guidelines for right-sided endocarditis are extrapolations from that for left-sided. So indications for surgery, we'll talk a little bit about this, but really congestive heart failure, most commonly from valvular regurgitation. This really has the largest benefit from a mortality standpoint with surgery, and this is also the most common reason to undergo surgery for infective endocarditis. Aggressive organisms, so Staph aureus is typically associated with a very aggressive course. Infective endocarditis that's very challenging to cure with antibiotics alone. Pseudomonas and fungi are just some examples, Candida being one. And if there's complications such as an abscess, heart block, which is suggesting an abscess, an intracardiac fistula, or highly destructive lesions, and this is usually seen with aortic valve endocarditis. Another indication would be persistent bacteremia. They've used the cutoff of 5 to commonly 7 days after appropriate antibiotic use. Recurrent emboli. Most emboli go from the left side, go to the central nervous system, but really they can go anywhere. And the highest risk of embolization is prior to the diagnosis being made, or initially, generally within the first couple of weeks. And the bigger the vegetation, the higher the embolic risk. Vegetation size greater than 10 millimeters in a setting of prior embolism, or just vegetation greater than 15 millimeters. That 15 millimeter one is much more controversial. Mobility is another thing that they look at, but once again, this is a little bit subjective, and there's high inter-observer variability with this. And prosthetic valve endocarditis has long been thought to be really managed with surgery and surgery alone. So this is kind of a flow sheet. We'll talk a little bit more about the timing of surgery. So basically what you look at, the big things are heart failure, embolic risk, persistent sepsis, and then complicated endocarditis, as we talked about. For right-sided, as mentioned, a lot of this is extrapolation from left-sided data. Once again, persistent bacteremia. The right side, they use a vegetation size cutoff of 2 centimeters. Some groups recommend a centimeter, but that's very controversial. Recurrent septic pulmonary emboli. Rarely you can get paradoxical emboli in the presence of an intracardiac shunt, such as a PFO. Aggressive or resistant organisms. Severe right-sided heart failure. This is not that common, but this would invariably be associated with severe TR. All of these in the ESC guidelines, they actually have more data in their guidelines than we do in the American guidelines. But these are all Class 2A recommendations. I'm sorry this came out a little bit fuzzy here, but once again, talking about how to manage this, there's IV drug users, stopping drugs, that's very intuitive. Non-IV drug users, if there's concomitant left-sided endocarditis, device involved. So these are all things that we would generally and commonly think about. Timing of surgery, and so it's kind of broken up into 3 different categories. Emergent surgery is generally done within 24 hours, most commonly for refractory pulmonary edema and or cardiogenic shock. Urgent is defined as not emergent and within a few days, so the definitions really aren't set in stone. That's usually for uncontrolled infection, complicated endocarditis with heart block, abscesses, vegetation that's getting bigger, or a large vegetation in the setting of embolization. Elective is usually done during the hospitalization, but in some cases can also be done after a period of medical therapy. Patients should be on appropriate antibiotic therapy at the time of surgery. I mentioned challenges in the differing definitions of the time course. And a particular example where the timing is really important is somebody that's had a CVA, an embolic CVA. Generally, at least what the guidelines would say is in somebody with a hemorrhagic stroke or a major ischemic stroke, which they basically define as a coma, you should defer surgery for 4 weeks. In anybody with a more of a quote-unquote minor CVA, you can do surgery kind of in a more of an expedited fashion. The concern is of hemorrhagic transformation of an ischemic stroke with anticoagulation related to bypass. This was a trial that looked at a small group of patients, 76 patients, all with left-sided endocarditis and a large vegetation size, looking at a composite of in-hospital death or embolic events. And really what they showed was that the primary endpoint was actually significantly reduced with early surgery, which they defined as within 48 hours, versus conventional treatment, which was surgery anytime after the 48 hours, mostly driven by a reduction in embolic events. This was thought to be a big study. It was criticized partly because patients were healthier than lots of cohorts we see with endocarditis, and they had a very low percentage of staph aureus endocarditis patients. But this is one of the trials used to dictate, 10 millimeters with the embolic phenomenon initially as a recommendation for surgery. So surgical principles, really trying to remove everything and anything that looks infected. With devices, it's worth mentioning there's higher mortality in patients that are treated with medical therapy alone without device extraction. And in tricuspid endocarditis, from a surgical standpoint, there's repair, replacement, and excision of the valve, which is valvulectomy. I think it's just interesting from more of a historical standpoint. This basically involves just removing the tricuspid valve and putting nothing in its place. One of the things on right-sided endocarditis, especially in IV drug users, is the risk of relapse and recurrent endocarditis, which I've seen many cases of that already. This is something that's not really recommended, but can be done in settings of normal pulmonary artery pressure and a desire to completely avoid putting anything in. The downside is most of these people end up needing some type of tricuspid valve replacement down the line. So guidelines, we went through a few of these, but really I've broken them down by class. So class 1 guidelines, as we mentioned, heart failure, resistant organisms, complicated endocarditis, recurrent emboli, and persistent bacteremia. Right-sided, it's a class 1 indication to prefer repair over replacement, which is really kind of a recommendation anyway. Having antibiotics at the time of surgery and removing any and all intracardiac devices. Class 2A indications for early surgery, recurrent emboli, mobile vegetations over 1 centimeter, and vegetations that are not changing. Relapsing infection in prosthetic endocarditis patients that weren't treated with surgery in the first place. CVA, as we mentioned, delaying 4 weeks with a major ischemic or hemorrhagic stroke. Anticoagulation, they generally recommend discontinuing anticoagulation even in patients with mechanical valves, although there is some controversy about that, but that's generally what we will do. And removal, I actually didn't know this, but this is a 2A recommendation. In the setting of staph aureus bacteremia in patients with a device, it's actually a 2A recommendation to remove the device even if there's no evidence of endocarditis because of the aggressive nature of staph aureus. So that's a guideline recommendation. 2B, most of these really talk about further characterizing the vegetations. If there's anterior mitral valve leaflet, that's thought to be of higher embolic risk. And CVA, we talked about this, so I will skip over that. So these are just a couple of other images of, not full cases I'll go through, but this is a 39-year-old lady that had metastatic squamous cell carcinoma. And as you can see here on this transthoracic study, there's a large mass here in the right ventricle. And once again, you can see here, right ventricle, pulmonary artery, nice view of the PA bifurcation here, but a clot, and actually felt to be a mixture of clot and tumor prolapsing across the pulmonic valve there. And this was a view of it on an apical 4 chamber, once again taking up a large part of the right ventricle, as you can see here. And another contrast image just for fun. You see the mass, at least part of it right here. And another quick case, a 32-year-old with newly diagnosed non-Hodgkin's lymphoma was having a pre-chemotherapy transthoracic echocardiogram finding of large mass in the right ventricle. And you once again see it down here in the kind of apical portion of the right ventricle there. This is a contrast image here of the mass you can see there. And this was actually felt to be metastatic lymphoma. Of course, no way to prove that, but that was the thought here. And this was a follow-up echo after, I can't remember how many months after chemotherapy, but as you can see, the mass clearly is not as dense as it was. You can still see part of it here. But he looks like this gentleman had some type of positive response to chemotherapy. So this is the last case I have for you. A 55-year-old male, no known past medical history, came in with an out-of-hospital VTVF arrest. Was having intercourse with his significant other when he became unresponsive. Just as an aside, as many times as I've heard this story as an inciter for myocardial ischemia or a cardiac arrest should all make us think twice. But anyway, moving on. When he arrived to the ED, he was in refractory VTVF, but eventually was able to get ROSC, and he had been intubated in the field. When he first presented, his vitals were actually pretty unremarkable. Labs were notable for a creatinine of 1.85. His initial lactate was 10.5. Troponin was 0.1, and his LFTs were abnormal. So this is his initial ECG. I'm going to turn this one over to one of the fellows. Dr. Frazier, any thoughts on the ECG here?
Thank you. You know, there's tachycardia. The ST segments in V5, V6 jump out at me. I feel like I'm missing something bigger than that. What else?
Yeah, pretty good. I mean, so there's no obvious ST elevation here, no clear current of injury. The only other thing you can notice here is there's Q waves in the inferior leads, which would suggest potentially a prior inferior myocardial infarction. So he was taken to the cath lab emergently to look at his coronary arteries. So this is a RAO caudal shot here. This is the circumflex artery. You'll see the LAD here. Really no mild to moderate disease in the system, but no significant obstructive lesions found. RAO cranial view, this is his LAD here, OM system up at the top of the screen. Once again, no severe, no focal lesions that were found. He had some 60 to 70%, 60% disease in one of his diagonals. Moving along, this is LAO cranial shot. See the LAD here, kind of right in the center of the screen. Circumflex OM system off to the right of the screen there. LAO caudal view once again. LAD here, circumflex system OM there. So really nothing too remarkable here. Right coronary artery, so much more disease here. Focal 60% lesion or so here, distal RCA. Really kind of Timmy-2 flow in the distal part of the vessel. Moving forward, another look at the RCA here. So this is the official findings here in terms of the coronary angiogram. Nothing was stented at this time. This decision was made to stop. We actually did a bedside echo after the procedure, and this gentleman had an akinetic inferior wall and something that looked like an aneurysm versus a pseudoaneurysm. He was admitted, underwent hypothermia, had recurrent VTVF requiring antiarrhythmics. Formal echocardiogram was performed. So really, what you see here is infralateral wall really looks pretty akinetic there. This is a short axis view. You kind of get this, and this is clearly akinetic, and then you're kind of seeing potentially a small something that's coming into view there, but not all that well visualized here. Left ventricle, you actually see clot, LV thrombus here. To zoom in on that a little bit in the bottom right, you see that right in the apex there. And this is really the findings of interest. So this is a look here at the inferior wall and this kind of bulging structure here that you see, and contrast images actually show flow of contrast into that structure with what looks like a little bit of thrombus there as well. So this was felt to be a pseudoaneurysm versus less likely an aneurysm. He was started on anticoagulation for the LV thrombus. When he woke up and we actually talked to him, he'd mentioned an episode a couple months ago of severe chest pressure, nausea, diaphoresis, and shortness of breath, which he didn't seek medical attention for. So the thought was that this is when he had potentially had his prior MI in the RCA territory, and his arrest was related to that scar in that territory. Eventually he recovered, and we proceeded with a cardiac CT to take a further look at what was going on. Short axis view of the ventricle, and you see this clearly abnormal cavity here along the inferior wall, the left ventricle. Sorry, this is a little bit tilted, but once again you see this abnormal communication here in the inferior wall. And a couple of still images of it here. Normally you'd expect this to be nice and rounded. Once again you see this here. So there was a lot of discussion had about this case. The findings were felt to represent a pseudoaneurysm, but we'll talk about the management of it, which is oftentimes surgical. But he was felt to be at high risk with his cardiac arrest, recurring neurologic function. And so our plan was to follow him very closely with repeat imaging. He underwent a secondary prevention ICD, eventually was discharged on optimal medical therapy for his coronary disease and cardiomyopathy. And since then, he's had multiple imaging studies that have shown everything's been stable, and actually he's had decreasing burden of thrombus both within the apex of the left ventricle and in the pseudoaneurysm. So just to talk quickly about LV aneurysm and pseudoaneurysm, we see much more aneurysms than we do pseudoaneurysms. An aneurysm is really a thinned area of dyskinetic myocardium, often accompanied by scar formation. The key finding is the endocardium and the myocardium are present in the wall of this, unlike a pseudoaneurysm, which is essentially a contained rupture that's contained by the pericardium alone. And it's important to distinguish between these two. Here's an image. This is an LV aneurysm, as you can see here. The endocardium and myocardium are intact. Here, in this case, they are not. In the pseudoaneurysm, this is just covered by pericardium. This is an example from ventriculography here in the apex. You get a look at a nice pseudoaneurysm of the lateral wall here. You see there's hard to visualize here, but there's a narrow neck, and this is the pseudoaneurysm cavity here. A couple other images, as you can see here, once again, on ventriculography and on echo. There's one at the apex, a nice pseudoaneurysm, and this is of the basal, of the inferior wall here. I think this gentleman had prior cardiac surgery, which was the association. Most of these happen secondary to an MI, especially in the setting of delayed revascularization. Post-cardiac surgery and trauma are common settings for pseudoaneurysms. Mostly asymptomatic, can present with a variety of symptoms here that I've mentioned. The most terrifying one is, of course, sudden cardiac death from rupture, which is higher for pseudoaneurysms than it is for aneurysms. These are usually diagnosed incidentally. The gold standard is autopsy, which we don't do for obvious reasons, as well as surgical evaluation of the tissue, which is also not a first-line way to diagnose this. Ventriculography was historically the diagnostic modality of choice. Now you'll see echo, CT, MRI. Really no guidelines for follow-up imaging after these have been diagnosed. Imaging findings that would suggest one versus the other. Narrow neck usually suggests more of a pseudoaneurysm. A wider neck suggests an aneurysm, but those are just general. You'll see aneurysms more commonly in the anterior wall and the apex, like that gentleman with the LV thrombus I showed you. Pseudoaneurysms most commonly happen with the inferior wall. The thought is if you rupture your anterior wall, there's really not much hope for you to even make it out of that process. The inferior wall, potentially the rupture is contained by the diaphragm and other supporting structures there. How you manage these, really you don't want them to get any bigger. and treating any symptoms people may have. So really afterload reduction, good blood pressure control, but once again, there's no great guidelines for this, but this is what we do. Anticoagulation if there's clot there. And a class 2A indication is actually to consider aneurysmectomy at the time of CABG in patients who have intractable arrhythmias originating from their or heart failure that's refractory to medical therapy. And prior studies that have looked at this have been in prior days preceding current medical therapy for coronary disease and revascularization for coronary disease. And they're rare conditions, especially for a pseudoaneurysm. Aneurysms are not quite as rare. And the rupture risk really relates to how long they've been there, so the test of time. Something's been there for months to years, it's less likely to rupture versus something that's acute. And the size is also important as well. So these are just a couple of reference slides. Thank you very much. Any questions or anything I can answer for anybody?
Great cases. That patient with the ICD mass is intriguing because it's always a challenge when you can do a extraction when you have a mass, and 2 or 3 centimeter has been proposed as something you look at, and if it's larger, then probably you should get the surgeons involved up front. And often we take them and do extraction when it's 2, 2.5, maybe up to 3, but it's often a strand, like a kind of a a thin something that's at maximum length. This looked huge, and it looked big in every dimension. I don't think, I was wondering, okay, I could have probably told you it would have caused what it caused. So I'm just surprised this patient went for an extraction without more kind of looking into it. The other thing related to that patient is the fact that he has long QT1. So I wonder, do you know what the indication was for an ICD?
He'd had an out-of-hospital cardiac arrest.
Yeah. So that's about the only thing that would justify an ICD at this point in a patient with long QT1. They don't. The last patient, this patient with EKG, I think he did have clear Q wave with ST elevation in the inferior lead, so which could be either an acute event or an aneurysm. So I just want to make sure that it was it was more than just a Q wave in the lateral lead. There were Q wave with ST elevation, which would go with the aneurysm. Yes, Staph aureus bacteremia, if there is no clear etiology. So if someone had a Staph aureus bacteremia and they had an infected prosthesis or something that caused it, then we're usually a little more patient. But if there's extremely low threshold to take devices out in unexplained Staph aureus bacteremia or recurrent Staph aureus bacteremia after you treated the primary source. So that is correct.
Amit, great job. Really phenomenal cases. I've been reading echoes for many years, and the LAA thrombus, LV thrombus, the RA, the right-sided masses are incredible. So can you go back to the decision about this last guy with the pseudoaneurysm about no surgery, right?
Right.
And I guess the other question I had is your last comment about the first case was he's doing well, which seems a little hard to believe given the pathology.
The pseudoaneurysm?
No, the first case with the endocarditis.
Yeah, it's remarkable. So he's been seen 5 times in clinic since he was discharged, and we send him home on no diuretic. He was remarkably stable. It's impressive.
He's living here in Minnesota?
Well, he's here for a couple of weeks and then is planning on going back to Utah. So I think that was the important finding with the dilated LV and 4 months of symptoms, that he'd just been living like this for quite some time.
So as far as surgery,
yeah,
no surgery for the pseudoaneurysm?
Yeah, so we had talked about it. The other thing I should have put in here was he'd had a small CVA, actually, also at the time, right around the time of his arrest. So the thought was that in the setting of somebody with a new stroke, LV thrombus, that we would kind of wait and see what this looked like on follow-up imaging, and the fact that we thought his event was 2 months or more before. But I know that this went back and forth for weeks trying to sort out what to do with this, and that was the ultimate decision that was reached with a lot of reservation about how he would do one way or the other. But he was pretty deconditioned after his couple-week hospital stay, and in the setting of a stroke, I think that was really kind of a couple of things that tipped them off from from doing surgery right up front.
But yeah, the conclusion was it was a pseudoaneurysm.
That was the conclusion.
I mean, it sure looks like it. It can be really hard to tell, and especially as things remodel over time, it's hard to tell exactly where the neck is. But I think there were a couple shots that I think you could see where the neck was originally.
So how was the decision made that was a pseudoaneurysm and not an aneurysm? And have you been able to find any chronic pseudoaneurysms that don't rupture?
Yeah, so in terms of how the decision, so it was looked at medical cardiology, surgery, a lot of different radiologists looked at it, and that was kind of the conclusion that was reached kind of based on the appearance of it, and like what Dr. Harris mentioned, in some areas where there's clearly, you can make a case that there's no myocardium surrounding the cavity, which would favor it being a pseudoaneurysm. When I looked at this, most of the data out there, they're little case series of 10, 15, 20 patients. There are patients out there that have been followed long term, up to, I think the longest one I looked at was like 5-6 years or so out, that actually are stable with these. Those were usually patients that were thought to have been subacute or more chronic aneurysms. I don't know of much data in people that come in with acute pseudoaneurysms and really, what their long-term outcome is. There's not a lot of data on this. That's the small group case report kind of series. So, but I think timing is something that's felt the test of time is felt to be helpful in dictating who's more quote-unquote stable from long-term complications. I think that's the end, right?
I think so. Thank you, everyone. Thank you. Please stop by and say thank you to Allie Moon for making it through the snow. Bristol-Myers Squibb could not make it this morning because they were stuck in their driveways. Have a great week.